a repeat for some of you that were here a few minutes ago. During today's sessions, we're going to be using Think Tank for question and answer. There's not enough time to do verbal Q&A with half-an-hour presentations one after the other. So if you have a laptop, you're welcome to log into the Think Tank system. The instructions are up there. If you don't have a laptop or would rather use one of our devices that are all set up and ready to go, there's a bunch of iPads over there and laptops over there. We'd like as many of you to have them as possible to pose questions to the speakers. There's some of them are doing quick mini surveys, that sort of thing. So do get up and grab an iPad or a laptop over there on the side and take it to your seat. Thank you. Okay, yeah, your hands will be busy. I hate these things. You in? Any iPad takers? I have one.
212. Can you hear me?
Again, for those of you just joining us, we'll be doing Q&A today using Think Tank. There's a series of laptops and iPads over there. You can log in with your own computer or use one of those things. They're already logged in and ready to go. Just take one. Don't take it home, but take one for now. And you're welcome to use those because we're not going to have time for many verbal Q&A questions. We will be starting in just a minute. If you don't have an iPad or a laptop logged into Think Tank, you might want to have one. It's a good way to pose questions to the speakers. The speakers have promised, even if they run out of time, they'll answer all questions that are posted in Think Tank. They'll answer them at least after the conference. They'll be part of our meeting notes. There are some laptops over there that are available for your use if you don't want to deal with the login process. You won't be able to get to your email from those laptops, and that's the point. Welcome, everyone, to the, let me give this guy a cue. Sorry, I'll do that again. Welcome, everyone, to the first annual CMS IT Convergence Conference. We're going to have a very busy day of many presentations about various aspects of IT at CMS. As I mentioned earlier, you'll have an opportunity to pose questions to the speakers using Think Tank if you don't have a laptop or a PC on your lap. There's several more laptops over there that'll fit nicely on your lap. Those are just connected to our local network, so those that are those that are remote won't be able to pose questions in that way. So we're counting on you to ask tricky questions to our speakers. And we will get started right away by welcoming remarks by George Linares, the CTO of CMS. Welcome, George.
Thank you. So I'd like to welcome you all, to those here and those virtually. I know there's some people online as well, to our first CMS IT conference, Convergence 2015. So why do we choose Convergence? We're choosing Convergence as the name is, we're trying to establish a branding here. It's because we're expressing the fact that we're bringing all of CMS IT together as one enterprise, working collaboratively across the agency with all components. It's an exciting time for CMS. But within these walls, there's so many initiatives taking place. And we know that technology is advancing at a rapid pace. And we're cognizant of it. So if you haven't noticed yet, CMS is embracing a number of new ideas, technologies, and approaches. We're open to it. Of course, it has to be secure. So today, you'll meet some of those people behind these key important initiatives that are advancing the agency. And in advance, I want to thank all the speakers and panelists for taking the time to be here and expressing their expertise as well. So during the conference, I'd like to ask you just one thing. It's just a minor thing, really. Be engaged. Be active. As David has indicated, we have the laptops. We got Think Tank. We have Twitter. You know, I've never tweeted before, so I just did a couple this morning. So please, engage yourself. be part of it, be online, and of course, if you haven't noticed yet, we have the booths outside from industry. Also engage with them and see what's going on, learn more on what's happening. I hope you find this session very informative and enjoy the conference. Thank you.
Thank you, George. I'd also like to introduce the CIO of CMS, Mr. David Nelson. You can.
Thank you, George. I didn't realize that you had actually Twittered. That's just amazing. We are really stepping into the next world here. Well, welcome everybody. This is going to be an exciting day, I hope, for all of you. And it's an opportunity for us to showcase some of the work that we really feel is innovative. I think you will too when you see it. It's not just CMS. It's you. It's the partners. It's the contractors. It's CMS. It's all of us together that are really making this happen. So. Thank you. Thank you for coming this morning, and thank you for all the work you're doing alongside of us to make this happen. The Centers for Medicare and Medicaid Services is continuing to make progress toward fulfilling our vision of high-quality health care, a system that ensures better care, access to coverage, and improved health. Innovation is the way federal agencies develop applications. This is a hot topic today. And CMS, we're proud of the leadership position that we're taking here. Healthcare data is not only being used to manage and drive improvements in healthcare, but through a variety of innovative ways, it's improving our lives. So I don't think we have to look too much further than the headlines each day in the news to find evidence of what CMS is doing in this way. Just from this morning, Washington Post, George Linares Twitters. Actually, the headlines say, you can now look up ER wait times, hospital noise levels, nursing home fines on Yelp. Yelp is adding a ton of healthcare data to review pages for medical businesses to give consumers more access to government information on hospitals, nursing homes, and dialysis clinics. Sure, CMS is offering this through Hospital Compare and some of our tools, but we're also allowing this data out there for other innovative companies, maybe more well-known, like Twitter, to use this data and really deliver new services. So I'm proud of this. I look at this every morning in the news, and I see something that has to do with IT, innovation, and CMS. So, again, this is you. This is all of our partners. This is our own employees and all the work that we do together. So today, we're going to hear about how CMCS has built systems to manage the oversight and operations of the $350 billion Medicaid and CHIP programs. We'll hear how OFM, how they're going to share their key challenges for High-Glass and their plans for enhancements. We're going to hear about the IDR, how it's maturing, how we're using a variety of new platform technologies to provide the right data, the right platform at the right time. OEDA, one of our new offices, is going to provide an overview of the enhancements to CCW and the innovative tools used to access and analyze that data, some of the outstanding data products that we actually put out there to the public. CPI is going to share best practices on the fraud prevention system, what they've learned to enhance that system. This system has served as the centerpiece of our ability to move from pay and chase to prevention and prevention of the payments to bad actors. CCSQ has been very effective in leveraging lean methodologies, and they're going to share some of those stories and the lessons learned there. CMMI is using Salesforce, cloud-based technology platforms for rapid application development. cloud-based technologies here at CMS. OC is going to talk about how we're using AWS for cloud-based computing environments. This is a FedRAMP certified Amazon Web Services, and how we've actually built that out now at this point where we have the ability to quickly and rapidly set up agile type applications. Again, I'd like to thank all of you. I think you are the reason that we're getting to this point, both our partners and our employees. I'd like to challenge you to ask those questions, to be engaged as George did. I'd like you to be part of this as you have been part of delivering the services we have today. But thank you again, and enjoy the day.
Thank you, David. As we get started, you'll see the screen up here, and the screen, if you have a laptop or an iPad, has changed. This is the way we're going to do Q&A over the course of the day, and we've told all the speakers that they should allow a little bit of time to respond to them. The way it'll work is I will ask the question on your behalf. Everything you enter into Think Tank is anonymous, so feel free to ask really nasty questions if you'd like. No? Speakers say no. Okay. So basically the way it works is you enter your idea down here at the bottom of the screen and press enter. And you'll see them rolling by kind of like a Twitter feed. You'll see the questions coming in. So the speakers, have a very limited time in their presentation, so they know that they may not get to all the questions. They may go through and pick a couple of questions that they can respond to easily, or that are questions that are really pertinent to their particular presentation. They have promised me that they will all go in afterwards and answer all the questions, so that if you ask a question, you will get an answer. Now, the answer may be, I don't know, or we'll look into that. But if you ask a question, we're going to try to make sure that everything gets answered. So if you don't have a laptop logged into Think Tank, there's a bunch of them over there that are available. There's no reason to have any of them sitting unused. So grab one. Don't keep it permanently, but grab one and use it for today. And let's get started. So our first speaker is Jessica Kahn, talking about the changing world of Medicaid and CHIP systems. You can speak over there.
Got it. Given my role, if I can't work the clicker, we have larger problems, right? I'm Jess Kahn. Good morning. I'm really glad to be here and to open this up. I see a lot of familiar faces, both in our vendor contractor community and within CMS. Really excited about this topic, and actually really disappointed that I can't stay here all day, because I'm equally excited about all of the other topics from my colleagues. I'm thinking about how we can maybe do a little internal lunch brown bag to miss what we couldn't stay for today. So I'm going to talk to you about Medicaid and CHIP and the IT work that we are doing to support the 56 programs with the states, the district, and the territories. Now, see, really? I'm not working the clicker. Okay. Please tell me it's not me. Try again. There we go. All right. So we did mention a huge amount of money goes into Medicaid and CHIP, so I'm just going to ask you a couple quick questions here. Which program serves more Americans, Medicare or Medicaid and CHIP? Okay, so you probably knew that was the answer, because why would I ask if I wasn't going to be happy with the answer? But yes, and how many of you actually knew that intuitively? Like that Medicaid and CHIP, okay, CMS people are not allowed to raise their hand. How many of our guests actually knew that Medicaid and CHIP had more covered lives than Medicare? Really good. Wish more of you raised your hands, but it's really important, especially when you consider who we're serving. It's not just low-income individuals, but we cover 1/3 of nursing home care in this country. Almost half of all births are covered by Medicaid. And then a number of course, children and just elderly and disabled. So we're actually up now to, if you include Medicaid and CHIP together, we're over 70 million people. in the United States and growing. We just are adding Alaska to the list of states that have expanded Medicaid. We're up to 30 states in the district. Okay, so CMS needs to receive a set of claims provider beneficiary data from states in order to perform all of our work. Agree, strongly disagree?
So you want me to do this on the survey? For those of you that have devices in front of you, your screen has just changed, and I'll change it so you can see it now. Quickly vote on your agreement or disagreement with each of these three statements. So the first one is CMS needs to receive a set of claims provider beneficiaries data from states in order to properly perform its oversight functions of the programs. Can we do all three at once and then come back to the results?
Sure, just as a little color commentary, just to remember, the states actually operate the Medicaid programs. CMS has oversight authority, but the states actually operate the program. So do we need to receive all of the data on all of the beneficiaries, all of the providers, all the claims, all the encounter data? The middle one is a gimme, right? Data must be timely, accurate, and complete. Who wants late, bad, and incomplete data? Anyone? Okay. And because Medicaid and CHIP program requirements are similar and often identical, it's cut off. Can you read the bottom of the last one? Can you see it?
I'll switch back to the ballot. Because Medicaid and CHIP programs requirements are similar and often identical, state system and business requirements should be standardized when possible for reduced development costs and increased component sharing. I am showing the results before you've all voted, which is kind of like, I'm from California, so that's kind of, we're used to that.
Early polling, that's what this is called, right? Exit polls. We are all in election mode 15 months sooner than we thought we'd be. All right. So the answer to all of these is, of course, and I'll explain a little bit more of why and how. So when we're thinking about why we would need this data, obviously we have it for Medicare, we have a strong data set on the market, people enrolled in the marketplace, but it's really important that we understand what we're getting out of Medicaid and all of the investment that we make in Medicaid. So who are we covering? Who's accessing care? Where are they getting that care? Is there good geographic distribution? Medicaid is a statewide program. You can't have white space where there's no providers or no way for people to get to their care. And understanding then the quality of that care and how much it costs us. Is there variability in what it costs for a prenatal visit in Colorado as compared to New York, and if so, why? And what goes into that? So understanding how the program works is all bubbles up out of this data set. And understanding about our providers, who's providing care to the majority of Medicaid beneficiaries? What about people who have specialty needs? Can they access a specialist or not? And of course, my colleagues from the Center for Program Integrity would like to make sure that these providers are doing so in a way that's not fraudulent or wasteful while we're at it. So this data set is the most fundamental part of our ability to do our data-driven work moving forward and understanding the investments that we make, what flexibilities we allow states to have. So states will tell you that every single Medicaid program is different. We got 56 unique snowflakes, right? And I get that, and I've worked in 2 states, and I've certainly seen that. But they all enroll beneficiaries, they all enroll providers, they all provide core services. There are now the same thanks to the Affordable Care Act eligibility criteria. And they pay claims, which are based on ICD-9, soon ICD-10. So there's a lot of standardization there. But where we do give states flexibility is around innovation. How do they want to treat a certain population in order to improve their health care? Do they carve out behavioral health? Do they carve out home and community-based services differently? How do they treat people who have in rural areas where there's perhaps a need for greater telemedicine? So we allow states to innovate in how they deliver the care and in some of their new and emerging payment methodologies also to be able to get more value-based purchasing. So having a consistent data set does allow us to also benchmark and look at that, not just for monitoring, but also if another state says, I really want to put nursing home into managed care, nursing home care, managed care. What does that look like? Well, now we'll be able to show them other states who've done that so they can benchmark. How long should I wait before I see some change in my costs? What's the sensitivity of the metrics that I'm developing? Really helps them look against each other as well as what we would need to look at with them. Data must be timely, complete, and accurate. Folks might be familiar with MSIS, the Medicaid Statistical Information System. That's what we've been living with up until now. And MSIS arguably doesn't knock it out of the park on these three adjectives. It is quarterly, not monthly, and of course it's quarterly not including the time it took for the providers to submit the claims to the state and the state to process them. Complete, not so much, and accurate, it's hard to say because there wasn't a consistent application of a data dictionary. So it might have been accurate for that state, but when you're comparing it to another state's data that define things differently, not so much. Okay. And we did, this one actually has to do with shared services and reuse and the investment that we make. Does anyone have a ballpark figure of how much money you think we give to states for Medicaid IT per year? Ballpark. Don't be shy. Come on, y'all just had coffee. Louder. Anyone? It is, on the average per year, almost $3 billion. Think about CMS's IT budget, and think about how much we're giving to these states to do Medicaid IT. Even if you set aside the unique snowflake argument, there is still so much that I've described that is common between those states that does not need to be built over and over and over again. Every single state had to modernize their claims processing system for ICD-10. We spent millions of dollars in each state for that to happen. There is a really strong argument, and for those of you who are in the audience who work not just for CMS, but also do a lot of state engagement, you've probably heard me on this stump speech for a while about trying to promote more shared services, more reuse, more open source of technology and software that CMS has paid for at the very generous 90% match. So, a little bit more turning inward to CMS. MACBIS, because we have to have an acronym for everything at CMS, is the Medicaid and CHIP Business Information Solutions, Business Intelligence Solutions. So in 2012, CMS, that's the Center for Medicaid and CHIP Services, OTS, all of which, by the way, we've gone through name changes since then, created MACBIS. And the reasons that we created this initiative were, first of all, in recognition of what the Affordable Care Act was going to be asking of us and allowing states in terms of delivery system reforms and testing of new methodologies, which you'll hear more about from the Innovation Center later. So all of the states and us were going to be on a path towards extensive system redesign and development. We knew that our current data environment here at CMS did not adequately support the needs of our internal data users for Medicaid and CHIP data, and that's not just our center who are looking at all the SPAs and waivers and compliance with our federal guidance, it's also the Innovation Center and Program Integrity and our Duals office and our Enterprise Analytics office. Everybody is very interested in this data set. Our actuary, it's a fundamental part of our agency, and we needed to upgrade how we were looking at that data. And I listed some of them here. We need to ensure better access at the enterprise level to our data sets to be able to facilitate effective program oversight. So what is MACBIS? This is like the bird's eye quick view. There's 4 pillars in MACBIS, 4 different kinds of data sets, and don't send me questions about what all those acronyms mean. Or I'll have to like phone a friend in the audience. So the 4 pillars, the first one is pharmacy. Obviously, drugs are really important. You know, Dave was talking about what he saw in the news. One of the things that caught my eye in the news this week is the state of New Mexico is going to spend $40 million this year on one drug for hepatitis in Medicaid. One drug. $40 million. So understanding what the investment is in pharmaceutical, in pharmacy, in all of the available treatments, which we want people to have access to, but understanding what percentage that is of their total cost and how that's being balanced and what rebates we might get for, and states might get for purchasing of those pharmaceutical products in large volume is really important. as far as the data set goes. The other one is financial. I've thrown a lot of big dollar amounts to you. States request money, we give them money, they reconcile all those big dollars. Kind of important to track. It's a good system to want to have. You want us to have one system that answers all questions about what we are giving to states in our matching funds. And so those systems are 15 years or plus old and need some reboot. The other one is operational data. So this is what I was talking about, moving from MSIS to transformed MSIS, TMSIS, but it's also our performance indicator data. For those of you who are watching our marketplace work, once a month in collaboration with the Assistant Secretary for Program Evaluation, we issue a report on marketplace enrollment. And it shows both the qualified health plan enrollment and Medicaid and CHIP enrollment. That data is derived from performance indicator data that states give to us. They also give us data on how long does it take for an application to be processed. And we are investing a lot of money in these systems. We expect there to be a high turnaround. As somebody applies, they should be getting answers. It shouldn't be a 45-day process, which is what it was before all of this. And CHIP enrollment and other kinds of data. PERM is the big one. That's the data set that states have to give to us so that we can look to make sure that they are paying providers correctly. This is the payment error rate measurement, and that's obviously operational. How well are states performing? What is happening? Data set. And the fourth one is program. So this is what I was talking about in terms of the different flexibilities we give states. It's the authorities. So if I say to you, look how much Colorado spent on managed care, look how much Tennessee spent on managed care, you can't do an apples-to-apples comparison. You have to understand, program authority-wise, what they were permitted to do, what we negotiated with them on a waiver in terms of cost neutrality, which populations and services they put into managed care, how long they've been doing managed care, and all of that information is program data that will allow you to do the analysis in an accurate way. So that program data ultimately is going to be in a system that we are building called Mac Pro. Everything is the Medicaid and CHIP at the top, keep things straight. And so that way we'll have some structured data, so you'll be able to overlay, if you put all these together, structured data on all these different data sets, so you could ask the question and have answers about states that have these similar authorities are paying for what, how much, and who are they seeing, and what are the outcomes, and what providers are engaged, and how much is that costing us, and how much is that costing the state in terms of total cost of care. It's a powerful data set, a powerful question to be able to answer. And all of this requires, of course, a unified data model and some consistency in how we're building it. That's why this isn't 4 separate development projects. We could do that. We could do just 4 separate development projects, never the twain shall meet, but we would not be able to put those 4 data sets together. And it's really more than 4. So MacBis is the pillars that brings it all together. Because we had to have a fancy graphic, this sort of shows the old issues and moving into our new solutions with the data validation, better data quality checks as the data is coming in so that we have more confidence in the data set, business intelligence and reporting, data integration, and comprehensive state integration is where we're going. Oh, stop to underline things. Okay, so what's changing? We have 17 separate systems with Medicaid and CHIP data right now that are supported by my group. Amongst those, there is not a unified data model. We don't have what I call enterprise change control. So you can make a change to one of those systems, but we aren't currently able to assess or make the cascading changes that would happen in those other systems. When I say no Medicaid or CHIP data steward, I don't mean necessarily that there aren't entities that are responsible, of course, responsible for the data within CMS. What I mean is looking across the use of Medicaid and CHIP data and understanding and empowering us internally to use that data effectively is itself a business line. Making sure that everybody knows the difference between Colorado and Texas is really important. Making sure they have that context so they can interpret the data correctly. We need to support that, and externally for external data use as well. Right now, or previously, old world, most of our production and data storage for those 17 systems was in the Baltimore data center. Hopefully most of you are aware of the CMS's migration to virtual data centers for most of our systems in the past year. Most of these data systems do not have a front-end quality check. We get the data, and then we call the state and say, what do you mean this went up this month? Why does it look so different? That's labor-intensive. It might make a few of our vendors very happy, because that's an ongoing book of work. So find another sustainable business plan, because we're done with that. We need to have quality checks as it comes in. And there was a lot of native and waterfall development, and you're going to hear hopefully a lot from my colleagues later this afternoon about Agile. New systems, TMSys, MacPro, Pharmacy, and MBES is our financial system. They are all undergoing or plan to undergo some sort of system redesign. That should say CDM, which is the Unified Medicaid and CHIP data model. Spending a lot of time working on that and talking to states now about it. States are, of course, running these same programs and are very interested in how we're developing our data model so they could remain allegiant to it also. We have followed the lead of our other partners within the agency about change control and thinking about it from an enterprise level. So if somebody over here wants to redefine what enrolled means, well, then all of those other systems have to be reassessed for how they're defining the word enrolled. And we have to think about the changes both to the data model as well as to a system in more of an enterprise view. MacBis data stewardship. So this is CMS's investment in making sure that as the data is being used, that all of that metadata and context moves with it effectively, and that we can support all of the emerging data use needs, both internally and externally. Something else that's new, of course, is use of Amazon Cloud. Most of these systems, the new systems, are going to be supported in Amazon Web Services. We have a data validation rules engine that applies business rules at receipt of the data. Heavy reliance on commercial off-the-shelf products. We're seeing faster development and faster turnarounds and reliance on COTS as opposed to native development. And we have a number of projects that are underway that are relying on agile development. Lots of change, right? This is all like 2012 to now sounds like it's been a while, but this is actually 3 years is a lot to accomplish that. Okay, moving quickly here. Who benefits from MacBis? And you'll have these slides, so I'm not going to read them all through to you, but it's a wide range within CMS. Of course, states, as I mentioned, to benchmark themselves, and external stakeholders who we hope would take our data, as many of you have, and others within the IT community to innovate and identify areas for improvement. Better data and better systems have a ripple effect across CMS and states' IT enterprise. So the idea is our investment in MacBis will necessitate greater enhancements and upgrades, not just for us, but with the states as well, to be more efficient and have stronger service delivery models. This all comes back to the consumers. This all comes back to better data for better care and services to our beneficiaries. Okay, so we've talked about this, and we have our brainstorming session here, ideas from you about what data and technology would better help us oversee the Medicaid and CHIP program. This is not make your best business pitch. Okay, leave your logo at the door for this one. This is truly, let's brainstorm. Like, what aren't we doing? I put a lot of emphasis on meeting with the vendor community. As busy as I am, I try to do at least 1 or 2 vendor meetings a month because I really love to learn about what is out there in emerging technology. I'm not somebody who, in most cases, makes purchasing decisions, so don't start lining up at my door for CMS enterprise. But what you are telling me you can do and what's out there in the market is generally what I look for then from the states. When they turn in a design plan for us and they want to put everything in their old mainframe servers, I can say, no, because nobody's building those anymore. And let's talk about all the other things I'm hearing from the vendor community.
Screen has changed if you are on Think Tank. Give us a couple ideas here. What are some new things that we could do? What are some implementation ideas? What are some things we can't do now that we should be able to do? And then I'm going to show Jessica what the questions are that have come up in the meantime, so that she can prepare brilliant answers. We'll switch to this screen after we get a few ideas.
Okay.
So what are some ideas? Think about it. There's a few coming in.
Okay, some good questions.
Let's wait for
Oh.
a few of these come up, and then we'll do the questions.
All right.
And I'll ask them when it comes. I'll read them, and you can answer them. All right, let's go right to the speaker Q&A. Let's get a couple more in here.
These are good questions.
Radiant comes up a couple there. Now when we go to the Q&A, which we're about to go now, so enter your answer, and I'm going to change your screen in about 3 seconds. 2, 1. So I'll read the question. She'll respond. If any of you out there are good typists, you could help her out by putting in the response on the right-hand side, the answer. Let me make that a little bit smaller. So the first question is, what approximate percentage of the needed data does CMS get today from the states?
Oh, I'm kind of greedy, so I'm going to give you a lowball answer on that one because I always want more. There are more data sets than I described to here. Of course, we receive a lot of data about quality measures, adult and children's health quality measures at the state aggregate level, providers who have adopted electronic health records and have done meaningful use. So it's what state data do we need? I would say it's probably only at the 50% level, and it's not because we may not have the data, but it's back to that timely, accurate, and complete. So if the question was what approximate percentage of the needed data do we have that is timely, accurate, and complete, I would say probably only at the 50% level. But again, I'm greedy, I like data.
What is the new macro legislation? How does the new macro legislation impact Medicaid and CHIP programs?
That's a presentation unto itself. So that one I will write a response to and share because there's quite a bit that goes into that that's beyond just IT.
Is there any method, process at CMCS to check the beneficiary eligibility before the data goes to CPI?
So it's provider data that CPI is most interested in. It's our Office of Financial Management that looks at data for PERM. So to be clear, states determine eligibility, and they have to demonstrate to us that their systems are accurate. That's part of the operational readiness reviews and the PERM oversight that we do with them. So they're making correct eligibility determinations. That's not new. That process has been ongoing. I think this TMSIS data set will allow us to do more examinations of that, but we are not double checking behind states across the board on every Medicaid and CHIP beneficiary. Determining accurate Medicaid and CHIP beneficiary eligibility for those who apply at the state is the state's responsibility, and we have oversight, but we're not coming along behind and checking every single one.
How friendly is your system and data available to the public for help when they need it, for help for what they need? Do you have any mobile apps or applications to support them?
So if by the public we mean people who could be looking for coverage and might be eligible for Medicaid and CHIP, that information and whether or not there are mobile apps and applications I'll talk to in a moment is really, it resides with the states. They're the ones that, as I said, accept applications other than being able to apply on healthcare.gov, of course. But otherwise, it's with the states, and they have, by requirement now, by law, under the Affordable Care Act, they have to have an online application. They have to be able to take the application on the phone, in person, on paper, of course, and online. Those are the same single streamline applications that we have at healthcare.gov or an approved alternative. So if you are looking at any state's Medicaid and CHIP application, it has gone through CMS approval. There are a few states that are moving into mobile technology, not necessarily at the application, but for managing your benefits over time. I saw a really great demo that Colorado Medicaid, I keep picking Colorado, I don't know why, but Colorado Medicaid actually does have an app where a beneficiary can go in and they can even find a local provider who accepts Medicaid. They have some mapping tools to get there. It's really an excellent tool. So there's more to come on that, but it's a balance. Like, we need people to be able to get to the providers and get there in a timely way. So we're really still at the place in some states where we're talking transportation, we're talking providers who will accept new Medicaid patients. Not to say I'm not a fan of mobile apps, but I want to make sure that it's balanced with other things that might be more basic IT needs.
So we've got about 3 minutes left and 4 questions. I'll answer number 6, yes. 5, 7, 8, we want to choose one of the others?
I really want to choose number 5, and
So
7 are together, actually, which is why on earth are we letting all these states build this all over again so many times, right? Where's the shared services? Where's the open source? I think that's really what both are asking. So 2 answers, 2 parts to that answer, 2 parts to that question. One is, if CMS itself received an appropriation in order to support Medicaid IT, of course we would build these things ourselves and then offer them as web services or hosted services, or we would put the solutions out there open source. That would be a perfectly logical step to take so that we don't have to pay for it 56 times. But that's not how our appropriation works. We receive a certain amount of funding to run the Medicaid and CHIP program that comes in our annual appropriation. The money that goes to states is not subject to an annual appropriation. It technically doesn't have a ceiling. So states request, and if they can meet the match, then we can meet the match on our side if it's an acceptable expenditure. So our hands are a little tied in terms of our ability to build it ourselves and share it. That said, we do have requirements already in regulation that what is built with our money has to, that we as the federal government have a free copyright access to that, and it is federally owned. So states have shared code. They could continue to share code, but there's a lot more improvement that could happen on that end to facilitate that. We have a notice of proposed rulemaking that was issued this spring. Comments have now closed, but one of the proposals that CMS put out there was how to engender greater support for open source and reuse within the Medicaid IT space. So we're still working in concert with states and our vendor community to think about how to make that happen, because we completely agree there has to be a greater emphasis on reusable and shared services and open source.
I think you have time to answer question number 8.
Ha.
There's another presentation coming later on that maybe will let you off the hook. But
So
go
I
for
won't
it.
say why we moved from VDC to AWS. I would say that when you look at, speaking for our programs, and when we're looking at where we want our data to be, it's not so much about where the data is stored. It's really so much when we're thinking forward about our analytical needs and the kinds of power that we need to scale up to do major analyses and then bring it back down, and that the rapid capacity that would be supported in the cloud. All of this data that we're bringing in is not just to have it, it is to enable all of the policy analysts, all of the data analysts, all of the program integrity analysts to use it. And you all know ease of use is key. How many of you had to take a day-long training for Facebook? Right? Twitter, anyone? Day-long training, 3 days, 4 days? No. It has to be usable. Like, you just get into Yelp, you sign in, and you look for a Chinese food restaurant. Like, that's the way it has to be here. I want to look at California's data. I want to understand who's going for care at the 21 hospitals that are part of our low-income pool. I shouldn't have to go into some complex tool and be a data analyst and able to do that. So part of our thought is what platforms are going to support our data analytical needs as opposed to just around storage. And there's more to it than that. And we still have, of course, other systems that are remaining in the virtual data center. So it's not a cookie cutter answer across all systems.
Jessica, thank you very much.
Thank you.
Our next speaker is from OFM, talking about the FMSG group.
Good morning, everyone. My name is Chris Martin. I am the Group Director for the Financial Management Systems Group, and I'm going to be providing an overview of my group, which I'm very proud of. I've been with CMS for about 2.5 years, and I took over as the Group Director about 8.5, 9 months ago. I had to bring my entourage with me because when the Q&A comes up, I need to have my experts help me answer a lot of the questions. I do know that we did have a change. First it was going to be 10 years of high glass, but I made a decision to make a little bit of, not only talk about 10 years of high glass, because I'd be standing up here for about 10 years to talk about high glass. So I wanted to give a broader overview of what the Financial Management System Group actually does. So my goal, oh, do I have a
Your voice is a little soft, so I'm going to give you a little, that's the clicker.
Got it.
I'm going to have you amplify yourself a bit.
Thank you. So how does this,
Pretty well.
okay, that, everybody can hear me, but the clicker itself, there we go.
It's all in the wrist.
Okay, terrific. So the Financial Management Systems Group is part of CMS. We are under OFM, the Office of Financial Management, and we report directly to the CFO. So the bottom line is I report directly to the CFO, and we are controlled by the CFO and directed by the CFO. We are not part of, so we are our own entity under OFM. So my agenda is I'm going to be providing an overview. Anybody heard of high glass? It's pretty big, isn't it? So I'll be providing the value of high glass, which is the Health Integrated General Ledger Accounting System. It's the Oracle Federal Financial System. We have some really neat things that we've just recently accomplished over the past year. ESMD, which is the Electronic Submission of Medical Documentation, as well as PSNR and STAR. There are two other applications that are non-high glass related that are in our purview. So what does FMSG do? We support over 27 OFM financial management systems, including high glass, ESMD, PSNR, and under this, the system operations for high glass are, one second. It's pretty much the operations and maintenance. We have a specific AIS contractor and a hosting contractor that provides all of the support. We provide security for high glass, both the NIST standards, segregation of duties. We have an organizational integration, supporting accounting operations for several lines of businesses, including Medicare, Medicaid, the Affordable Care Act marketplace that was implemented a little bit about a year and a half ago, back in January, as well as the administrative program accounting. And we develop and maintain information technology program systems. So for high glass, on the left-hand side of the screen, that was our prior environment. So 10 years ago, we celebrated our 10 years of high glass on Cinco de Mayo, 5th of May. But that's what the previous environment looked like. It was over 50 some odd legacy systems. And those were consolidated into one Oracle Federal Financial Accounting System 10 years ago when we went live. So you can understand the complexity of trying to manage and maintain and operate 50 some odd systems and trying to gain reports out of all those systems that were consistent. So that was I was not here during that time, but my predecessor, Janet Vogel, who's standing in the left-hand corner here, was here during that time, and I know that must have been an extremely monumental task and challenging, as well as several folks here on the stage that were part of that team. Mary Carol Stifler, and I'm sure there's some other folks in the audience, but that was a monumental task to consolidate everything into the Oracle financial system. And it's a COTS product. It's a commercial off the shelf, not, the C doesn't stand for custom. And as everyone knows, when you're dealing with a commercial off the shelf product, there are unique business rules within the federal government that are not always accommodated within the Oracle system when they say it's federalized. So unique enhancements, I'm not going to say customizations, had to be built in order to accommodate CMS's unique business requirements. As I mentioned, we had over the past year and a half, we had a very interesting year in order to be able to be compliant with not only Oracle, because they were no longer supporting the current release that we were on, R11, and we had to go to R12 to be compliant, as well as we went through a year of an assessment, and we have roughly 8 million lines of enhanced code, custom code, to handle our unique business processes here within the financial system. And so we had to do an assessment to identify which lines of code would we remediate, redesign, and map that to the R12 environment. And there was, the main goal was to try to reduce the amount of customization for the return on the investment, and the return on the investment specifically was our AP/AR netting. Oracle did not have, in the release 11, a solution in the APR netting. That was a CMS enhancement that we built into the R11 product. So that piece right there was a key component as part of our upgrade. We were not allowed the luxury, when we went forward with the approval from OMB Treasury to go move forward with the upgrade. It was not enough. There are two upgrades. You have a technical upgrade or you have a re-implementation. We could not do a re-implementation. We had to leverage the Oracle technical upgrade scripts. When we kicked that off, the scripts, without looking at any of the performance tuning of those technical scripts, it took a little bit over 69 days to do the upgrade. That was just running the scripts without looking and tweaking the upgrade scripts. Bottom line, that was not acceptable because we could not afford to go dark, meaning shut down the application and not make any payments. And I'll get into some of the statistics later. So the team sharpened their pencils, moved forward, and we were able to do the technical upgrade in 4.25 days. We were down for 5 days, but the actual end-to-end technical upgrade was 4.25 days, which was monumental. Roughly 40 terabytes was our production database that we upgraded. That's phenomenal. Do have some statistics in terms of 6.9 billion records were upgraded. And within 36 hours after opening up the application for business, we processed roughly $6.9 billion worth of payments. Our future strategic plans for improvement, even though this list is not really exhaustive, it's going to require a lot of analysis. We currently have in R11 we have an HP archive solution. In R12 that HP archive solution will not work. So we're going to have to look at our HP archive solution, and our current archive solution in R11 is only for the accounts payable table for the benefits data for Medicare transactions, not for the administrative program accounting data nor the marketplace data. We will also leverage or looking to expand our business analytics. OBIE is our reporting tool. And those are some of the key initiatives that we're looking to expand on next year. ESMD, electronic submission of medical documentation, is the exchange of various types of medical documentation, requests and responses between Medicare providers and CMS review contractors via the health information handlers. Bottom line, it reduces paper. There are over 490,000 medical records sent through ESMD in FY14, an increase of 7% from FY13. As everybody sees, there's a steady growth in number of participating organizations. There are 23 HIHs that are certified by CMS to offer ESMD services, and there are 29 review contractors that are approved by CMS to accept ESMD transactions. The initiatives going forward, bottom line is to just reduce, add new functionality to reduce paper and snail mail. PSNR. is a provider statistical and reimbursement system. And bottom line, it's a data warehouse that contains all medical Part A claims processed and paid since 2007. And it provides analysis reporting for Medicare Part A payments to the providers, the MACs, and CMS. PSNR produces more than 300 different types of reports, including annual cost reports, detail of beneficiary claims, summarized payments across various bill types, and statistical and payment reports. There are more than 300 different reports to include annual cost reports, as I mentioned, and these detail of beneficiary claims, summarized payments across various bill types, statistical payment reports are just to name a few. The system for tracking, audit, and reimbursement, STAR, is a web-based application used by CMS and MACs to track Medicare Part A costs, reports, reviews for audit and reimbursement. The bottom line, PSNR is used by providers to get paid claim data to CMS in preparing their cost reports. STAR is used by the MACs to monitor and track the cost reports submitted to providers. The future of PSNR is to incorporate the IRIS functionality. IRIS is a tool used to reduce the overpayment to teaching hospitals, resulting for their utilization of interns and residents. For both PSNR and STAR, we are planning to move forward with a SOA environment, and this will allow a real-time integration between CMS and the external systems to include MAC and the provider systems. I will open it up for any discussions.
We do have a few questions.
Sorry.
Is the Provider Compliance Group, PCG, moving to CPI?
I can't comment on that question.
All right, let's skip to number 3. How much money has netting saved CMS every year?
So every month we recoup $1 billion.
Okay.
So every year, do the math. 1 billion a month, 12.
What's next for High Glass?
So what's next for High Glass? As I mentioned, it's the archive solution as well as, okay, so with the upgrade, as I mentioned, first of all, we've done the technical upgrade for the 3 lines of businesses, APA, Marketplace, and MSP, the Medicare Secondary Provider. Because the database was so large, we had to partition it, and we only upgraded to R12. We're actually currently running 2 production environments, one in R12 and one in R11. We're still running the benefits in R11. After we did the technical upgrade, we kept the Medicare benefits data in the R11, and we're transitioning or converting that data, and that started in the June timeframe, July, and into August. So every week we are converting roughly 2 to 3 MACs every week, with the exception when we do month-end close. We have to shut that down because the accounting team has to do the month-end close process. So in August we will have all of our data in R12. We're going to be doing a year-end, and then looking at the archive solution as well as our reporting analytics. And that's going to be it. We're still going to be staying on 12.2.3 is the version that we're on. There are 2 other Oracle Federal Financial Systems within the department. There's UFMS, the Unified Financial Management System, that it's at the department. It's one set of books, it's one instance, 4 sets of books. And then there's NIH, National Institute of Health. They're on a different version. They're on 12.2.4. We're on 12.2.3. Whether or not we go to 12.2.4, to be determined.
Question number 5, do you have any plans to integrate these 3 systems, especially on the data warehouse capability?
Okay, so that's really a two-part question. So integrating the 2 systems, can I clarify that question? Who asked that question? Are you trying to ask whether or not we're trying to collapse UFMS and NBS and High-Glass into one system? Because we're not going to do that. There are 3 unique businesses that we're accomplishing here. CMS is all about benefits, primarily benefits. UFMS, that's handling FDA's lines of business, CDC, Indian Health Service, as well as a program support center that handles the 7, I call them dwarves, and I got that from my old boss, who's also sitting in the back, but AOA, ARC, SAMHSA, HRSA, and then NBS, that's all the research grant stuff. So those 3 we will never collapse. That has been discussed, but in my lifetime, I don't think that will ever happen. Whether creating a data warehouse for all 3 systems, we currently have what is called CFRS, the Consolidated Financial Reporting System that the department owns and manages, and we feed data on a monthly basis down to the department at a consolidated level. Whether or not they need our data from the benefit side, they don't get that data. They only get the administrative program accounting data. I don't foresee that. I think we're more primarily concerned about CMS's data to build that data warehouse for my reporting solution.
Number 6, what is the next initiative that ESMD will implement to be fully functional with the FFS systems?
Yes, I'm going to hand that question over to Ed Klein, who is the Division Director for DPSS.
Sure. Actually, it's a good question time-wise because I believe it's probably next week, Tuesday. There's a kickoff meeting for analysis CR, a change request, the purpose of which is to automate that interface between ESMD and the shared system. So right now, when medical documentation comes in, it comes into ESMD from the provider side. We send it off to the MACs, and at that point, the MACs are basically taking it from one screen and typing it into another, which nobody would think is a really good solution. Obviously, in order to scale up, if you're talking about doing thousands or tens of thousands or 100,000s of claims, that process needs to be automated to the extent possible. So there's a change request in place to do it. The discussions on that start next week. That'll be the first thing. I'm sure there's more that could be done in terms of, in the future, in terms of better validations up front, or instead of just making sure that the requests we get are like syntactically correct, looking a little bit deeper into them with structured data. That's still in the future, but certainly on our business team's roadmap. But really, that automation piece is next up, and I would expect to see it in calendar 16.
Can we jump to question number 9 while you're up there, Ed?
So are there any plans on offering ESMD as a free service, if not already, to encourage more use?
Sure. And again, we're not from the business side, but I'll give you the answer that I think that they would give, which is that CMS doesn't charge for that service. The HIHs do charge for it, and that's sort of the question of trying to subsidize that in some way. I know there's been some small internal discussions on that, but I think they're certainly looking at ways to boost, encourage more use. I know they've put together a roadmap of where they want things to go, and we've got some suggestions on that which we've been sharing with them and will be. But I'm not sure that that's something that, making it free, we're not the ones charging, so it's a little bit complicated in terms of how we would make it free.
So is High-Glass moving to AWS as well?
No.
DME to High-Glass on the schedule?
It is on an unpublished schedule. We have a preliminary schedule in place. We are just working through the current funding issues. I can't, that's all I can speak to at this time.
Number 10, are you using any cloud capabilities supporting your 3 systems?
Yes, for High Glass we are. We're using the virtual VDI, virtual desktop integration, and that is for all of our developers and folks as they manage, maintain, and operate High Glass. That's one of the
And
cloud
level 11,
tools.
how secure is your data seeing the OPM security breach?
I cannot comment on that. No, yes. It's very secure. It's very secure. We're not public facing. We are within the CMS net, and we're not in the VDC. We're not in the BDC. We have our own hosting contractor, and it is extremely secure. We have very tight controls protecting High Glass. We're constantly audited, and we go through a rigorous security process to ensure the integrity of that application, and it's very tight.
Great. Thank you very much.
Thank you.
Thanks to the efficiency of our speakers, we are almost exactly on schedule. We appreciate that. Time for a little break. Please be back in exactly 20 minutes at 10:35.
Thank you. Yes, Lisa. Yeah, absolutely.
We do. I have my own company, and
Right.
we actually been working on things that have to do with. We're on the BIET.
It just depends how it's.
Should I
Test 1 2 1 2.
should I encourage people to use this guy?
Huh?
Should I encourage people to use this guy?
Oh, this.
getting out of here.
Okay, well, what I was thinking is, I mean, I guess I could. What if you have both those? Is that a problem? Because I'll probably stand right here, and then I was just thinking I would sit down, let her hop up, and then.
Yeah.
Okay.
And I'm better at standing too. And we're about the same height, so I think we're probably
Yeah, I think we're okay with the mic.
we're good.
So we control our own fate here with this clicker? Yes. And I'll see there what's up there? Perfect. Perfect.
I guess I have no, my water bottle just. Who was that guy on that politician that was had to go like off screen? You don't remember that? No. He was doing like an afternoon.
was just going to say,
Yeah.
but I'm just going to talk about, I'm going to introduce you to kind of talk about the plans that we're having
Yeah.
and what our goals are. And then I'm going to start a little bit of work with this current state of the art. So just kind of talk about what it is from the side that most people have. But that's much more than that. And that's what I'll do.
Yeah.
Okay. So it's from 9 to 5 fair Wednesday.
Somebody's got to do it, right?
Oh yeah, we have a chair here in the middle of the stage.
You can distract everybody while we're fumbling over our words.
So is there any particular other? So what I'm going to say is I'm going to say I'll introduce you to, and I'm just going to say something. We invited people to say, we want you to be able to ask us questions about the idea of systems perspective. We also thought you might want to get a perspective from our key stakeholders whose business depends on that. And so you may want to ask me some questions about physics. So I'm trying to encourage people to put those sort of questions in, just so maybe Kathy has some sort of. It's funny because he told us to submit some seed questions in case he asks a question. He'll have somebody ask us some softballs to start with. So we'll see. But did you see? I came in
It is time to get started. It's overtime. You guys going to be 30 minutes? In order to keep on track, in spite of the fact there's people in the hallway, I think we should just get started. They're late. We're on time. Why should we wait for them? So let's get started. Our next speaker, talking about OTS, IDR, and beyond, we'll have Mark Hogel, Julie Slater, and Ray Wedgeworth. Take it away, gang.
All right, thanks, David. Welcome. Glad to see so many people here today. I tell you what, these events are really a lot of fun, really interesting, and when you see a large crowd assemble like this around here, I'm always excited, and we look forward to a lot of good discussion with you all. So thanks for coming. First of all, I'd like to introduce Julie Slater. Julie Slater is the Deputy Director of our Division of Enterprise Information Management Systems. In that division, they operate and maintain the Integrated Data Repository. And I'd like to thank Julie and Jen Mooney, the Division Director. They have done a lot of outstanding work. They've had a lot of interesting challenges over the past year, and they've really met them they've faced them head on, and they've really nailed them out. So thanks a lot, Julie. Secondly, I would like to introduce Ray Wedgeworth from the Center for Program Integrity. So the Center for Program Integrity is a key stakeholder for the IDR. We do a lot of work with them, and Ray in particular is a really solid partner that we've had a lot of good success working with. Ray agreed to join us today because what I'd like to do is, the format today is going to be fairly simple. We're going to try to speak for maybe 10 or 15 minutes, keep it fairly short, and then we want to have a more open and interactive discussion. I'd rather not talk at you for 30 minutes. I'd rather kind of give you some information and then we can have a dialogue. But I'd like you to think about questions from two perspectives. One is you can ask Julie and I, of course, a lot of IT questions about the system, where we're taking it, that sort of thing. But then keep in mind that we have someone that's a key business stakeholder on the stage that could answer questions around their perspective about how things are working, what Ray's finding is, to be successful, what he's happy with the IDR, maybe what he's sad with, but mostly what he's happy with. So we're going to have that kind of a format. Our goals are really, I would say the first goal really is to bring you up to speed on the current state of the IDR. The IDR has now been around for almost 10 years, believe it or not. It's been quite a journey. And so you probably wouldn't be surprised to know that some things have changed. We've integrated a lot of different data sources with the IDR over the years, so you may not know that. And we've added some capabilities. So we really want to kind of bring you up to speed on where we are today. We also want to talk about where we're headed in the future, some of the new technologies that we're introducing, where we're trying to take things, and help you understand that. And then, in the end, of course, then we want to have, our third goal would be to have some interactive dialogue with you folks to find out, maybe what you're thinking in this area, and maybe you have suggestions that we'd want to keep in mind. Okay, so let's start with the current state of the IDR. So I'm going to read you one sentence just so that it's clear. We've written down that the IDR is an enterprise data warehouse that integrates Medicare data and supports many CMS mission-critical programs such as high-tech, ACOs, physician value, 1PI, and many more. So the key there is it's one of our critical data warehouses, and it supports many programs and has become part of the fabric of CMS that's very, very important. We started the journey with IDR around 2005. We did a bake-off, I think it was in 2004 actually. They came up with the solution, started implementing in 2005. And now we have data in the IDR as far back as 2006. We have claims data for Part A, B, and you may or may not know that the IDR is the system of record for the drug data processing system. So we have Part D data in there as well. So a lot of people think of the IDR as just that. We have the A, B, and D claims data, and that's the IDR. And it's much, much more than that at this point. We have grown from a 9 terabyte platform to a approximately 550 terabyte platform today. So as you can see, things have changed a bit, and I'm going to invite Julie up to talk to you about some specific data sources that are now in the IDR. She's not going to read them all off because she would be up here for quite some time, but she's going to talk about some of those data sources, what programs they support, and then some of the new features and functions that we've added into the IDR as well. So Julie?
Thanks, Mark. So the IDR has 42 major data sources. And some of them Mark already mentioned in the claims area, but some in the claims area that you may not be aware of is that we have shared systems claims data that comes directly from the 3 shared systems. And we get that data daily, and it's in a couple different phases, so it allows more closer look at the claims. We also recently have loaded the Medicare encounter data into the claims subject area. In the beneficiary subject area, we have your traditional, we have CME data, which is the Marks MBD, EDB data, but we also have data from the risk adjustment systems like risk scores and monthly membership reports. In the provider area, which is another important data area in the IDR, we've had PAYCO's global extract file for a while, and same with MPI crosswalk. More recently, we've added sources like provider of service and Part B provider extract, ProvBX, so we've built that out a little bit more. And that's about it. We've got a couple hundred reference tables, and I'm not going to go into those, but the IDR has grown as far as its data. Another feature of the IDR is Data Labs Data Marts. And what Data Labs and Data Marts are, they're logically separated space within our production data warehouse. And how our business partners use these data labs and data marts, they can store result sets that they created in the IDR, and they need it for their program use or for further analytics. They can also use it to include external data sources that maybe aren't in the IDR or not in the IDR presently. These data labs, data marts are used by many different business components, and I'll tell you a little bit about the programs. CPI uses data labs, data marts to support their National Fraud Prevention Program predictive modeling development. They also heavily use it for their one program integrity so that their different ZPICs and medics can come in and use the IDR. CM is another business component that uses this feature. They use it for the ACO Shared Savings Program. They use it for physician value. And they also use it, the MACs use it for national utilization analysis. CMMI is also a big user of data labs and data marts. We have the Pioneer Accountable Care Organization that works out of the IDR, a couple other ACOs like Learning Systems, and soon to be Next Gen ACO. And then we have just a couple components like CCSQ and OACT and OEM that use it for general data analytics. We also have external partners like Office of Inspector General who also use the IDR heavily for data analytics. Back to you, Mark.
Thank you, Julie. Very informative. So I want to mention something else about the current state of the IDR. So for those of you that are familiar with mainframes, they typically purchase a mainframe and put it on the floor, and it's got many, many engines in it, but you don't turn them all on, and you pay some lower amount of money. So if Sherry Wilkie's in the crowd, she'll vouch for me on that one, Sherry. So we've taken the same approach with the Teradata platform that supports the integrated data repository. So some years back, we put a platform on the floor that was a 600 terabyte platform, but we were in what they call a capacity on demand model. So we only turned on about 300 terabytes of it. Over time, as we needed it, we bought increments and we turned them on as needed, and it worked out very well for a number of years. So last April, 2014, we turned on the last increment of the Teradata platform. So that 600 terabyte platform, we were getting close. And we knew that we were going to be in the 550 terabyte range this time of the year. So we already had been planning, but we continue to plan and make a more solid plan towards what exactly we were going to do this year. So in July 4th weekend this year, we actually migrated the IDR data over to a new Teradata platform here in the Baltimore data center. You may or may not have noticed that. Hopefully you didn't unless we told you. And then, of course, it was important for you to know. But, so we made that migration happen in July. So we have a new petabyte Teradata platform on the floor here in the Baltimore data center today. So let's go on to what our goal is. So our message has changed. So in the past, most people would equate IDR to Teradata. We use those terms sort of interchangeably, right? Because that's pretty much what it was, besides having the normal tools around it like BI tools, ETL tools, and those sorts of things. The primary platform was a Teradata platform. But we have introduced Hadoop, and so now we're saying IDR equals Hadoop, Teradata, and other technologies. So that's our new message, right? Okay, so, and I told you that we migrated the IDR data over to a new Teradata platform in July, but there's more to the story, right? So the next step in the story is that we've taken the production, what was the production Teradata platform, and we're reconfiguring part of it to be our lower environments. Now, when you're in a data warehouse environment, you almost never have the luxury of having lower environments that are exact duplicates of your production environment. It's just too large, too expensive. Most people cannot afford that. So it won't be the same size as our current production environment, but it will be a more robust environment than it's been in the past. So that's a key piece. This fall, September, October timeframe, you're going to see that reconfiguration take place. One driver that we always have is optimizing the use of storage. But we also want to move just beyond managing storage, right? I mean, to date, the main driver was storage. As we get more and more claims data, we had to increase the size of the platform. And performance really has not been an issue for us for the most part. But that's kind of coming to an end. We are really starting to see a huge, large user base that wants to use the IDR, and we have to be a lot more careful about performance and how we manage that. And so that's a key component. And so to that end, we are introducing Hadoop as part of the IDR environment. We recently installed a 333 terabyte Cloudera Hadoop 5.2 platform on the floor in the BDC. Teradata is still a very big part of the IDR, there's no doubt about that, but we really just want to optimize both platforms for what they're best at. So you're going to start hearing us use the terms, that data is in the Hadoop side of the IDR or that data is in the Teradata side of the IDR, so don't be surprised when you hear that. So what is Hadoop? So Hadoop is a distributed, scalable, fault-tolerant, open-source platform. I mean, this has been around for a while. I think at least some of the techies in the crowd will know what Hadoop is and that sort of thing. But we believe that it's a beautiful complement to our current data warehouse environment. We think that we can bring it in and we can make it do some things that we think are best for that particular platform. Some of the good use cases tend to be centered around batch processing needs and parallel execution using MapReduce. So it's also important to note that we now have some significant experience using Hadoop. We are always hesitant to sort of jump on the bandwagon with a new technology and start using it before we know it's solid. I'm not sort of like, I like to be on sort of the leading edge but not the bleeding edge, if you will. So we're careful about that. But at this point, Hadoop's been around for a while and we've cut our teeth on it a little bit. So for example, the Multidimensional Insurance Data Analytics System, or MIDAS, is the data warehouse for all things Affordable Care Act. So we have MIDAS in production. It's on a Hadoop, Cloudera Hadoop platform. It's been up now for several years, actually. The bulk of the data in MIDAS is the marketplace data that we pull out of the marketplace every morning at 12:10 a.m. But it has a lot of other data, too. In fact, it predates the marketplace first open enrollment. We have data from earlier than that in the MIDAS platform. So we have some good, solid experience using Hadoop in production. We also did a proof of concept. So as data flows from our common working file through into our warehouses, we have something called MQA, MQR, which is our Medicare quality assurance and receipt and control systems that do some things to the data to ensure quality, some edits, et cetera, before it gets passed down to the warehouses. We did a proof of concept with Hadoop to see if we could do that a little bit better, and we were able to do it faster. We believe we were be able to decouple things a bit so that when changes happen in the claim system, we can sort of isolate the downstream warehouses to a certain extent. So again, we've had some good success with Hadoop. So there's some pretty solid reasons why we would go to that platform. And at the bottom line is that we now have some significant experience with Hadoop, and we believe we're ready to incorporate it in the IDR environment. So it's on the floor in the Baltimore data center today, but it's not part of production yet. We'll be working towards that, getting an ATO, authority to operate, and incorporating it throughout the year. Okay, so what are some of the good use cases for Hadoop? Three things that come to the top of mind. There are many others, but I'm just going to talk about three things primarily. Data profiling. So because of the cost of the lower cost of the Hadoop platform, we believe we can create a data lake where we dump all the data. So we can be a little more accepting of all data. So in the past, we've had to profile data and say, do we really want to put this data in our Teradata platform, right? What we want to do now is say, let's put the data in the Hadoop side of the IDR and profile it and figure out, should this data be moved over or not? That does a few things for us. It optimizes what we're moving over, but then later, we haven't lost data. So if later we find out, oh, we should have put these data elements in and we didn't, we haven't lost them. We can go back and say, now push those over from the Hadoop side into the Teradata side. So I think data profiling is a big thing here, and it'll be very helpful for our warehouse. Temperature-based storage. So we use the terms hot, warm, and cold in most data scenarios to talk about data that's used a lot, maybe data that's used a little or rarely used. So typically we don't want to put our cold data, the data that's rarely used, on our most expensive platform. So you'll be seeing us moving out on a plan where we take data that looks like it's cold and that hasn't been used in a while, migrating it over to the less expensive Hadoop side of the IDR. And then data production line. So I like to use the term data production line to describe primarily what the Enterprise Data Services Group does. That whole production line of data we manage for a lot of the agency's data, not all, but a lot of the agency's data. We believe that a lot of the functions that Hadoop provides will enable us to automate those functions, do them more quickly, in a more scalable, cost-efficient way. So you're going to be seeing us working towards items where as we ingest data, we say, let's not ingest it directly into the Teradata side. Let's ingest it into the Hadoop side, profile it, figure out what to do with it. Does this really suit itself to go into the Teradata side of the platform at the right time? So it's not just a matter of all data goes on every platform, and if you use it, you use it. You don't, you don't. We want to have the right data on the right platform at the right time. So that's our message, and at that point, we're willing to take questions.
We just have a couple. So are Medicare Encounter records to be part of the IDR?
Medicare Encounter? Yeah. Medicare Encounter data is in the IDR currently.
Okay. And are there any additional technologies being considered?
Yes. So it's interesting because I mentioned Midas, and on Midas we've learned a lot. And these two teams are sharing. What's really kind of interesting and fun is that these two teams are sharing a lot of lessons learned. So on the Midas side, they learned some things around ETL tools. They were having a little bit of a problem with Informatica Big Data Edition. They decided to go over to Impala. They've learned some lessons there. Just one example of something that happened. There are all kinds of new technologies that are maybe better suited to big data platforms than they are to the Teradata platform. Let's put it that way. So integrating them can be a challenge. So what we're finding is SAS on Oracle. How does that work? How does SAS work on DB2? How does SAS work on Cloudera Hadoop? Right? I mean, there's some challenges that we face, and I've talked to many of you about those. So yes, there are other technologies we're considering. We're looking at things like Tableau. We're looking at things like Platfora, Impala. A lot of these technologies that are around Hadoop. And Hadoop itself, of course, has a whole suite. I mean, if you go look up, the suite of software that's really Hadoop, Scoop and Flume and Hive and Pig and, all those fun names. All those things, we're trying to figure out the best way to use those. Now, another key thing is we specifically made sure that we went to the 5.x version of Cloudera Hadoop because we wanted to have Spark. So if you look up the Spark, S-P-A-R-K, Spark, capabilities that are provided in that platform, that's another technology that I believe we'll be taking advantage of.
The next question is, Hadoop ecosystem matures. For example, MapReduce, wait a minute, is this the response to the question? Okay, do you envision that CMS will leverage the massive parallel processing capabilities to do a lot of things that Teradata currently does and save money?
That was a softball, Sumant. Was that him? Yeah. So right. I mean, it's funny. I didn't even see that up there when I spelled Spark. SPARC is what we're calling our new enterprise systems development contract, so not to be confused with that. So Spark will be and is part of the new platform. We will leverage that. I mean, to do a lot of what Teradata currently does, I don't know if a lot's the right way to say it. All I can say is that we know certain things lend themselves to batch processing. Both platforms are, massively parallel processing kind of platforms if you think about it. So, I mean, we introduced Teradata as an MPP platform here. But with MapReduce, Hadoop does a lot of those things as well. So, we've been thinking more along the lines of where can we store a lot of data and profile it? Where can we do batch processing kind of things? And then when we think about the Teradata side, we think, where can we do analytics in place? If I need to do analytics across a lot of data sets and I need to do it and it needs to perform, that's Teradata's game, right? So again, right data, right platform, right time. Optimize the use of each platform.
Number 4, how do you handle queries across Hadoop and Terra?
So as far as the queries across Hadoop and Teradata, we'll be evaluating probably a couple different things, but Teradata Grid is a feature that's available in Teradata release databases to allow for to be able to query against both of them and get one result set back.
Are you considering expanding the use of Hadoop into real-time analysis analytics in the near future?
So I would say that we're considering that, but I would say that's probably not near future. I think we have other priorities ahead of that to use the platform. Again, open to suggestions. I think that is coming, but I don't think that's our first move.
How are other BI tools, external data sources, evaluated for the IDR?
Well, I think it's two different questions. I think BI tools, some BI tools, again, I think were kind of built from the ground up for certain platforms. They do very well at integrating with particular data platforms. So, we look at those criteria to pick the BI tools. But it's, in terms of like examining an external data source for IDR, do you want to take that?
Yeah. I mean, that's usually based on business need, and it ties into kind of question number 7, and I'll say yes. I don't know when, but yes.
And the question, for those who can't read it, is Medicaid data to be added at some time?
Yes.
And the answer is yes. Any other questions from the audience?
All right, if you're not going to do it, I'm going to ask Ray a question. So I think it'd be interesting to hear, what Ray thinks about the current platform and what has been important to them and valuable for them in having this warehouse with this data in it, and maybe even talk about what you want to see in it later, Ray, some of the data.
Thanks, Mark. When Mark first asked me to sit with them, I asked him if it was because they needed the eye candy. He said no. So I'm glad he at least asked a question so I could try to be helpful. So for CPI, what's really important for us is to have a program integrity community. So the fact that we built out our one program integrity, offshoot of the IDR is really important to us to be able to work with our partners in law enforcement, the medic, our zone program integrity contractors, doing our own data analysis in this environment was really critical to us. And the fact that we can get access to Part A, Part B, and even now we have Medicare Encounter data, so that's Part C, and we have the Part D data. And the shared systems data has been really useful for us too, because we don't just care about what we've paid, right? We also are interested in folks that are pinging us and having denials and what's actually going on out there. So that's really important to have all 3 phases of a claim as well. So it's a very robust environment for us. And the fact that we have business objects, we have stars in this environment now, and we have SAS, allows us to get people access to the data. They all don't have to be super power users, right, to necessarily use stars, but some people are power users and they want something more complex, so they use SAS. So we have multiple tools that can be leveraged to really get to the information we need. The other initiatives, such as building a semantic layer over the data that we have in the 1PI environment, also helps in that access. I could say we had struggles early on in that the IDR, the way it's structured, has hundreds of tables, right? And a user has to go in and bring those tables together to get useful information out. Well, now the IDR and 1PI have semantic layers that allow easier access and easier ways to pull down the information for those end users, so they don't end up with all those Cartesian joins and all the things that create, bring down the system and cause it to fail. So there's been a lot of progress in recent years on the ability to access the information, analyze it quickly, and then making that information actionable from a program integrity standpoint. So while the team of Mark and Julie and Jen Mooney and many others in OTS, they hate to see CPI coming because we want something new and something fast, but they've always been responsive. And what we want to do now is we want to move to newer things. We want to do more geospatial, better visualizations in that environment. So we're moving into those areas now.
Okay. Right. Any questions for Mark? Great. Thank you very much. We'll move right to our next presenter, Chronic Conditions Data Warehouse with Andrew Chateau, Ronnie Tan, and Michelle Seal.
Ready? Oh, I'm being timed. I'm officially on the clock. Okay. My name is Andy Chateau. I'm Director of the Data Development Services Group in OEDA. And one of the main projects under my area is the Chronic Conditions Data Warehouse. So today we're just going to be talking about what exactly that is, what we do, and some of the data inside it and who uses it. So first, sort of the origin story. The CCW, the Chronic Condition Data Warehouse, was mandated under Section 723 of the MMA, which was back in 2006. Section 723 mandated that CMS, there's only one, designed and built a database to study beneficiaries with chronic diseases. Obviously, we know most beneficiaries have at least one chronic disease. There's only a very, very small percentage that have none. And the beneficiaries that have, I don't know the exact numbers, but let's say 3 or more diseases spend the vast majority of dollars and services through the Medicare program. So it's an extremely vulnerable and it's extremely expensive and it's extremely critical population. So as we started the project back in 2006, we initially designed data cubes. We designed what conditions we were going to study. We picked not only technically chronic conditions, but also high-cost conditions that had sort of chronic follow-up treatments, even if the condition itself wasn't necessarily chronic. And we used a 5% sample of Medicare data. Wasn't a lot of money in the law to build a database. And by the end of 2007, beginning of 2008, we had our flags. We designed chronic condition flags. And then we started deciding that since most beneficiaries have chronic conditions, and we needed most of the data from CMS in order to design the flags and build the stuff, we might as well pull in all of the data and have the control group of people who don't have conditions so we can see as people evolve into developing conditions and those sorts of things. So our users, right now the chronic condition, then in 2010 the chronic condition also merged with what used to be called the Research Data Distribution Center, the RDDC. And so the Chronic Condition Data Warehouse is our research data warehouse at CMS, and it provides all data to anybody who requests data from a research organization or basically anybody externally from CMS. So last year we delivered, you can see the statistics up here, there were 304 PUF requests. You might be wondering why someone would pay for public use files. Some of the data at CMS is so incredibly large we just can't put it on the website for download. So we charge, it's very small, $20, $50, something like that, and send CDs. So those are very, very small requests. LDS files, remember under HIPAA, there are 2 standards for identifiable data. One is RIF and one is LDS. RIF contains a direct PII identifier, so something like a social security number, name, email address, that sort of thing. LDS doesn't contain that information. All the PII has been stripped off, but you could still probably use the data to identify somebody if you worked hard enough and had a third-party source. So for instance, if you see a Medicare claim and somebody was hospitalized with a broken hip and a broken wrist, and you find a newspaper article about a car accident and the person's named and the newspaper article says they had a broken hip and a broken wrist, you've just identified that person. So now that person, if it's in the newspaper article, clearly disclosed what they had. They clearly told the newspaper article they had a broken hip, or somebody gave consent, but through the claims you can now link them to other services they had that they didn't consent to be revealed. So you can identify that person and identify claims that they did not want revealed, which is usually the situation you get into. A lot of people consent to revealing certain elements of their healthcare utilization, but not others, and when you put everything in a database, you're going to link them together, and that's the issue. So that's those requests, the LDS requests are our most common and they're our cheapest to produce. Because there's no identifiers, they're a lot easier to build. We have standard products. We only encrypt them with the DESI sort key, which is a standard encryption key at CMS. So they're more common and cheaper. The RIF requests much more expensive to produce. Each identifier, even though we have a universal identifier in our system, each request is encrypted separately. So that if Harvard receives a file and University of Maryland receives a file, they can never put them together. Their identifiers are going to be different. So it's longer, there's more quality control and things like that. And then we also have virtual access through the CCW. You can remotely connect into the data itself. We have currently, those are our use, we have 50 federal users, 25 external, those are academic, 186 CMS employees and 400 contractors. Most of the contractors are CMMI. Contents. So the strength, just like the IDR and all of our integrated systems, the strength of the system is the unique key that allows you to connect all the data from the different programs together. So for instance, HIC numbers change over time. MSIS state IDs change. Lots of states will give a Medicaid person 2 separate IDs. If they're in the program at 2 different points in time, they give them 2 different IDs. So we have crosswalk files that link all that together. We have all the Medicare claims from 1999 through current. We load them weekly. We have all the Part D events, and for all the Medicare claims, we keep all the variables now. We didn't originally start with all the variables, but for the last several years, we're loading all the Medicare variables. Again, it's one of those situations where when we were building it as a research database, we said, these are the claims researchers will use. These are the claims no researcher's ever going to use. And as soon as you identify something a researcher would never use, then you'll find a researcher that needs that variable. It's like saying Beetlejuice 3 times. They're just going to pop up somewhere and need that piece of information. So it's just far more efficient for us to load everything up front instead of going back and fixing stuff later. The Medicaid data we have is MAX data. So that's a downstream product off of MSIS. We have a customized product that actually MMCO, the duals office, created. It's the Medicare-Medicaid link files. So that's all the Medicare and Medicaid utilization for the dually eligible population. So you don't have to try to put it all together yourself. And then all the assessment types, and we're always adding new data sources depending on the business needs of our customers. So right now we're loading MA encounter data. We're in negotiations for TMSIS. We've loaded risk score data, things like that. These are our predefined chronic conditions that we originally started with. All of them have sort of algorithms. Obviously, they're not designed with testing, or we don't have chart records to confirm that someone was diabetic. We have to use Medicare claims, so we have to build algorithms to define if someone received 2 diabetic services within 6 months, then they're diabetic probably, because if they only had 1, it could have been screening. They might not actually be diabetic. So we have algorithms for each of these conditions. All the algorithms were created by panels of industry experts back in 2006 when we originally created the database. So this is, again, for researchers, it's a shortcut to allow you to get down to the population you want to analyze a little bit faster without every individual researcher chugging through all of the data. We also do other special customized files for research. Again, the duals office here has developed some additional flags on the Medicaid population. Mental disorders, disabilities disorders. We've built those into the Medicare population as well. Some of the conditions are the types of conditions that are more focused in Medicaid than Medicare, but we've put them into both, we've created flags for both populations. We have a lot of characteristic files. The Part D files, especially, you get the physician's NPI and you get the plans and things like that. So we've built characteristics files to give you some more insight into that, like what the characteristics of the pharmacy were, the prescriber, the plan they're enrolled in, the drug itself, things like that. So there's just sort of auxiliary research files. The master Benny summary file is our denominator. There are several segments, but it tells you, it has one record for each person. And it has their characteristics of when they were enrolled in Medicare, month by month, their age, race, things like that, geography. Again, we mentioned the linked files, and we have the Medicaid enrollee supplement file, which is essentially our denominator, our master Benny summary file for the Medicaid population. So those are companion files, one for Medicare and one for Medicaid. More about the virtual access. So obviously, the Medicare program keeps growing. Researchers want more and more data for accurate results. The data is getting extremely expensive for us to produce and ship out to researchers. So about a couple of years ago, we piloted and experimented with allowing researchers to come in and use the data physically in our environment. It's also a lot safer, obviously, than having copies of data floating around the ether. We built the VRDC back in 2013. We officially launched it. We built it in 12. It's just, and again, it's a trade-off. If you're doing a small study with a small amount of data, it's cheaper to get physical provisioning of data, and we still allow that. If you're doing a large study, multiple years, 100% data, that kind of thing, you're going to want to use the VRDC because 1 year of Medicare data is about $100,000. So 1 year of VRDC is about 40. So if you're getting 5 years of Medicare data versus 1 seat in the VRDC, in the VRDC you're not paying for data, you're paying for IT. You're paying for the licensing, the seat, the output review, stuff like that. Whereas if you're buying data, you're paying for me to produce it all, encrypt it all, check it, things like that. So it's just a lot cheaper as you move into huge quantities of data to use the VRDC. The user requirements, again, one of the limitations of the VRDC, if you receive data, you can build your own, you can use your own software and things like that. I can't exactly make every piece of software available in the universe in one system. Most users use SaaS, so we have SaaS. We use Enterprise Guide 7.1. We just upgraded our SaaS environment. We had a significant upgrade. We moved from 5 large Oracle M5000 servers to 16, 20, something like that. Commodity servers all linked with SaaS Grid, so the system is significantly faster. And again, if you know how Grid works, what that means is your program, in the past it would be focused on a particular server. So if you submit a program, it finds one of the server with the lowest capacity, it hits that server, and that's where your program's going to run. With SaaS Grid, your program's going to hit all servers, and they're going to run sections of your program simultaneously so that overall your program's running faster. So what you'll see when you get the result is it'll say CPU time 3 hours, real time 1 hour, because you use 3 hours of CPU time on different CPUs, and it only took 1 real hour. I think there are 250 nodes within our SaaS environment now. So, and again, a lot of that is driven by the CMMI use with their 400 contractors. I think CMMI started using the database 2 years ago, and within that 2 years, when we converted the SaaS environment, we had to move all the SaaS data sets, so we took a look at everything CMMI contractors and employees have built in the last 2 years, and it ended up being just over 5.5 million SaaS data sets that we had to convert. So they have been very actively using the SaaS environment for the last couple of years. Also, on our website, ccwdata.org, one of the things that we try to do a lot, as opposed to more of the operating systems, is because we deal with our customer base, our external people less familiar with the program, less familiar with how to analyze our data. We put up a lot of training videos, a lot of instruction guides, a lot of documentation. So we have one-on-one videos, which are, we don't teach you SaaS, but we teach you how to use SaaS efficiently in our environment, how to connect, things like that. And then we have a whole course catalog. If you're actually a user, you'll get notifications about different trainings at different points in time. And we also have Stata, because lots of people like Stata. Lots of the researchers like Stata. We also have a workbench tool that we design. So what this is essentially a software shortcut. This is all keyed to the data use agreement for the user. Everything is keyed in the CCW to the data use agreement. So if your data use agreement says you have access to 5 years of inpatient claims, let's just say at the 100% level, and then you're doing something where you need to identify just beneficiaries 65 to 74 in a particular state or something like that, instead of coding all of that, you can go into the Workbench tool, use drop-down boxes. You're only going to be selecting what's available through your DUA. But you'll select inpatient claims, you'll select your age categories, you can pick specific ICD codes, things like that. And then you run it, it'll run in the background, generate your output, all the claims that meet that criteria, and put them in your workspace, so that you don't have to develop the big programs off of the raw data. We also have a cohort estimator. Again, because it's designed for researchers, most of our physical provisioning, the pricing is based on your cohort size, how many people. But this can be used for a lot of other applications, so it's publicly available on our website. But any of the variables in our master Benny summary file, you can just run online on our website and find out how many people meet that criteria. So in this example, we picked people 55 to 65, so people disabled transitioning into Medicare, full Medicare, but obviously already in Medicare. All months of eligibility, have diabetes. We picked a specific diagnosis code, and we looked at all 3 claim types on the Part A side, and we'll just submit that, and it'll tell you how many people meet that criteria. So you can break it up by geography, things like that. So we use it a lot internally if you need sort of a quick number for, a lot of times they're speeches, but for a quick fact for the Medicare program, how many duals in this state, that kind of thing. And then the cohort tool feeds into the pricing tool. The pricing tool, again, largely used for researchers. Your cohort size, you can either put in your own if you have a Finder file. Lots of researchers already have a file of Social Security numbers and things to hand us. So you can, or you can automatically populate your cohort. And then you can pick what files you're going to be requesting. As you select each box, another box comes up with the year. So if you pick SNF, I can say, 2008 to 2010 or whatever you need. And then it'll do a cost estimate for you to show you how much it will cost. A lot of researchers need that because they're building grant applications and they need to estimate the cost way before they actually need data. So that's largely what the cost estimators used. And all of our costs are publicly available too on the ResDAC website. So the main points of contact here, the CCW team, this is my staff. We have our own mailbox for VRDC questions. This is largely VRDC users and people who are asking about the environment, but that's just vrdc@cms.hhs.gov. The CCW, the data center itself, has a website, and that includes the tools, the cohort tool and the estimator, and all the documentation and what data is available. And that's just ccwdata.org. And then ResDAC. ResDAC is the Research Data Assistance Center. So that's where you go. They don't have the data. A lot of people get confused with that. They don't possess Medicare data. They help researchers with the DUA process. They help them design their research study. It's at the University of Minnesota. It's a team of epidemiologists and health services researchers who can tell you if you're studying whatever it is you're studying, use these Medicare files, use these variables, here's how you ask for it, here's how you go to your IRB, here are the HIPAA waivers, things like that, so that when the request eventually comes to the CMS Privacy Board, it's a little easier for you to get through and expedite it. So the ResDAC is sort of a help desk for research. And that's the CCW. Where's that little thing? Oh, you have it?
We do have a couple of questions.
Okay. Why not migrate the CCW to the IDR? Well, first of all, the two are architected completely different. One is Teradata, one is an Oracle Star schema. One is designed for large-scale processing, one is designed for research. The other big issue is because the IDR is used for CMS programs, Part D program runs out of the IDR, it's the system of record and things like that, there is a much higher level of security in the IDR, which means it costs a lot more to do stuff in the IDR. The CCW is a tier 2. It's a lower system. It's a moderate level. So we're allowed to have a lower level of security because it's used for research programs. The program doesn't stop if something happens to the CCW. Everybody keeps moving on. Claims get paid. People get enrolled, things like that. That may not be the case if something happens to the IDR. So there's a lot more redundancy built in the IDR, and it makes it a lot more expensive to operate in that environment. And researchers, it's a cost scale. Researchers we don't need to build that expensive an environment for research. So don't build it. And plus, trying to get all those users into one system with all their different needs, researchers have very unique needs. It would just become very, very chaotic. Implementation of changes would take much, much longer. Because we're separate, we can be a little bit more nimble. We can add data and change Oracle structures very, very quickly. You know, the IDR would never be able to do that because that Oracle structure may be feeding some Medicare program, and therefore the impact could be significant. So it's just a lot more flexible to do them separately. And I think we did have a few, we had sort of this was many years ago, but we had, as we talked about the IDR and CCW as both were being developed years ago, we talked about integration and we brought some experts in and IBM and a bunch of industry leaders. And I think the response was, one of the best response from their lead architect was, you can integrate all CMS data into one primary system, but you should start by building your own power plant because you're going to have a huge capacity. The heat put off is going to be tremendous. You need a ton of power. It's just not going to work. And if all your data is in one spot, how do you know when something's wrong? How do you check it? We have tons of redundancies at the IT level to make sure power comes back on and things like that. But we need redundancies at the data level too to make sure stuff is being loaded correctly. We benchmark the CCW and IDR data all the time to make sure that there aren't any problems with loading either system. So there's a huge advantage to doing that.
Okay, I think you've addressed the second question.
Oh, did I?
Yep, I think so.
Okay.
You can look at it, make sure.
Sure. I guess I need new glasses. National Data Warehouse work together. Yes, they do work together. We share load processes. The IDR is fed from the fee-for-service claims from the MQA process, as Mark said. So is the CCW. We try to leverage as much efficiency as possible between the two systems, and we try to benchmark the two systems together as much as possible.
Okay. Any other questions from the audience? Thank you.
Thanks. And I'll also say they were very quiet up here, but obviously as the manager, my job is like the guy who drives the dog sled. I just carry the whip and let everybody run. So it is my staff that make the system actually work and make it usable. So Ronnie Tan and Michelle Seal are my two leads, and I want to especially credit them for their work.
And speaking of eye candy, we're bringing Ray back to talk about implementing a new technology, FPS successes, challenges, and best practices.
All right, thank you very much. So again, I'm between you and lunch, so I'll try not to take up the full time. What I'm going to talk about today is the fraud prevention system, but I'm going to do so in the context of implementing a new system, right? The FPS isn't new. We're going on our 4th year now. We've had 3 reports to Congress, so it's not a new system now, but it was in the beginning. And I want to talk a little bit about those experiences. And at the end, I'll wrap up with what are some of the best practices that we learned through the process. And hopefully people can look at those best practices in a generic frame. It's applicable to other IT projects when they're implementing something new. All right. So, all right. So what I'm going to talk about first is just the FPS, sort of for those who don't have a background in it, what it is, what the authority was to actually put in the fraud prevention system. Then I'm going to talk about outcome measurement and what we measured. And then I'm going to tout some of its successes. We've had our 3rd year report out now, and we've made a tremendous amount of progress through the years. So the system's working really well for us. And then I'm going to wrap up by talking about the investigative process and then those best practices. So to start off, the FPS technology was authorized under the Small Business Jobs Act of 2010. So what was great about that is that Congress not only put the legislation in, but sometimes where this doesn't happen, they actually put money behind it as well. So we are given a lot of resource to implement this system. But of course, with that comes a lot of responsibility. We had a lot of funding, and so we had a lot of scrutiny, a lot of stakeholders in this system. As we were trying to build it on day one, we had people auditing us before we even started, right? But that's important, okay? Keeps us straight, keeps us, working hard on a project. But since June of 30th of 2011, we have been running predictive algorithms and other analytics nationwide. All this information is then presented back to an end user on a daily basis. So it gets out to our zone program integrity contractors and regionally and our PSCs regionally on a daily basis. And for the first time in the history of our program, CMS was systematically applying advanced analytics against Medicare fee-for-service prepaid claims on a streaming nationwide basis. So we're streaming 4.5 million claims on a daily basis coming through this tool that's alerting on providers, on risk profiles for providers that then go to our zone program integrity contractors to investigate. Okay. So in the first year, to get everything started, the first pieces we had to deal with was to build the FPS foundation and infrastructure in a very, very short time frame. Kudos to some of the original architects, include Dave Nelson and Mary Agnes Loreno, Kelly Jant, others that had this vision, but also worked really hard to meet some very stringent timelines. I think the system was up and this is Kathy Wolf, she's the deputy director, and she's happy I'm pointing her out right now. She'll handle all the hard questions at the end. So, you know, Kathy was here as well in the development. When we started out, I think the system was up in 90 days, which was a really, really tight time frame. So from that time period, though, we've made a lot of enhancements, added many, many more models, and so forth, and we'll talk more about that in a moment. So one of the important things that was learned pretty early on is you need a governance structure, right? You got to have a governance structure to prioritize the models and enhancements to the system to make sure that the investigators are getting the right information for things to be actionable. You had to make sure that everybody was trained on the system. We also had to build out an analytics lab. That's where I came in not long after the system started to build out an analytics lab and data analysis expertise through both our internal and external partners. We established collaboration and partnerships with standard business practices. We solicited incorporated user feedback and so forth. And one of the other important pieces is knowing that how much we needed to work with the business user, the user community. We developed a command center, a center of excellence for fraud, waste, and abuse. So we leveraged that command center, and I'll talk about how that helped us in a moment. Okay, so the first thing is we were given all this money, right? Well, Congress was smart to say, okay, we're going to give them all this money. How we know we're going to get a return on our investment, right? So in the legislation, they said that OIG would certify our savings calculations from this system. So it required the Secretary of HHS to submit reports for each of the first 3 years of the fraud prevention system implementation. It also required the OIG to certify certain components of the report, primarily the dollars, right? How much is it costing you, and how much return on that are you getting through savings? And we recently completed our third-year report to Congress, and in our second year, we were able to receive OIG certification. Okay. One of the interesting things about certification, everybody kind of shrugged at first and said, well, what certification, right? Because, you know, OIG, they do audits, right? So what is a certification? So we had to work through all of that in the first year and so forth, but we finally, you know, settled on what it was, and what it was a financial audit. So they got through the financial audit, and then we were certified, right? So some of the key saving calculations, I'll just go through these really quickly, are things such as revocation. So we're estimating the amount of payments that CMS avoided by revoking providers. This is a really important piece because you can imagine financial auditors agreeing to a methodological approach that would be accurate enough to say, you know, while we don't really see the money coming back, but we revoked a provider, how much did we save based on what they've billed us historically and how long they would have billed us forward? To actually get an agreement on the methodological approach and to say we certify that approach was really key to us because, as Dave Nelson said at the beginning, is that, you know, we wanted a system that would move to prevention, right? If you move to prevention and you're preventing dollars from going out, how do you measure what you've prevented, right? And how do you get that audited? And so that was a challenge for us, but thankfully in our second year we got certification on that, and we've used that in the third year too. So now we can measure that. The whole industry is happy about it, the private industry, the public industry, because we got to show our value in prevention. In other words, it's hard to justify the investments. Payment suspension, so that's where we can suspend money for periods of time. Overpayments that are recovered, that's more of the chase side, right? So we identify what kind of overpayments already went out the door and try to pull those back. Auto denial edits, so this is where we get the pesky human beings out of the way and say, okay, we're just going to stop this claim. prepay review and law enforcement referrals for more criminal activity. Okay, so tout the successes. So in our first year, the fraud prevention system, based on savings due to FPS, was about $115 million, right? In that first year, though, as we were trying to figure out what is certification, how are we going to do it, we really ran out of time. We were not certified in our first year of the program, which was a disappointment, but I think we were in a learning stage, both OIG and us, on how to work together, how are we going to do these. And so it became a heavier lift for our own internal staff in doing all of this work, but also as a heavier lift for OIG. They put more resource on it as well. In our second year report to Congress, we made significant progress in almost doubling the amount. We had a portion of a little over $200 million that was certified by the Office of the Inspector General. And then there was a section up here, there was quite a bit, about $40 million, that were savings that we counted that OIG didn't certify, but they still let us put it in a report and everything. But the issue was how are we measuring things such as when you already have a case that started, maybe there's a beneficiary complaint that comes in the door. If that complaint comes in the door from somewhere else other than FPS, then we didn't initially see it. But if then the analyst then goes and has this beneficiary complaint, goes to the FPS, and it augments that information, or it helps to expedite it because you have data at your fingertips, actually move it forward, we think that's a value as well. So that's what that piece is. So in the third year report to Congress, we were up to $454 million, and we also got certification on that area of savings due to investigations, expedited it, augmented, or corroborated the information from the FPS, moving our total to $454 million. And also we increased our savings due specifically to the FPS as well, going from $210 million to like $320 million or so. So over that 3 years, we've totaled $820 million in total savings. We're approaching that $1 billion mark. That's a goal for us. And so we're very happy with its success. However, there's expectation that we're doing $1 billion a year, not $1 billion over 3 years, right? So Congress is pushing us hard, and we're coming up with more innovative ways to leverage the FPS system, and we'll talk a little bit more about that. Okay, so quick overview. So that's touting the success. So it's been we're happy with the success, but there's a lot more to do, and I'll talk about some of the things that we'll be doing. But a quick overview of the process for fraud prevention. The first is developing those models and moving through the fraud prevention system, generating those leads for investigators, the investigators moving, taking action, and then getting ultimately to the Medicare savings. Now historically, that lead, investigative, action savings, the old way, and I think I might even have a little rocket in here that kind of goes slow. Look how slow that rocket is, right? Because we got to go through all of these different institutions and people and policy experts, and we would do so in a very linear fashion, right? So it took a long time in even developing a model to get to something is on historic claims, paid data, and then we'd have to contact all these various folks. So the new way is we introduce the fraud prevention system, and we introduce those leads, the models that we're doing and so forth in the command center. So we go into having more people there at the point of time in the command center as we're looking at a model, looking at a trend, thinking about new ways to take action and using the data in an actionable way. And look how fast look at that rocket. That's amazing. All right, so bringing all those folks together, much, much better. All right, there's also a new analytics approach. It's not like the zone program integrity contractors weren't doing data analysis before the fraud prevention system. To the contrary, they were all doing proactive data analysis, and they do proactive data analysis today. But what the fraud prevention system helps us to do is to take different types of analytical approaches, bringing it all together on a provider on a national basis. So we really understand that full book of business of providers, and we work together collaboratively to take action on them. And then we also learn lessons, and fraud moves. Fraud moves from Miami-Dade to Detroit. fraud moves from the East Coast to the West Coast, and people that have seen the fraud and have an understanding of the fraud and have found the best ways to deal with the fraud, if that gets shared in our program integrity community, that's how we get to more efficient models, more efficient actions, and so forth. All right. So real quickly on expanding the FPS. So we really, I don't have a pointer up here, but if you go to the far end where you have intentional potential fraud, where you had the most egregious actors, that's really where we started with the fraud prevention system. It was important for us to get those most egregious folks first, and these are folks that you want to refer to law enforcement, but you also want to take a lot of administrative action, you want to kick them out of the program, and so forth. But we can leverage the fraud prevention system in a lot of ways. If you say that you have, okay, you have the top 100 providers you want to deal with in this particular region of the country, what's wrong with 101? What's wrong with 105? What's wrong with number 200, right? There's still a myriad of issues that we identify. And so we really are working on, you know, if there's limited errors, then we want to educate maybe and see if we can see behavioral change, lesser interventions. Or the other area that we're moving into is in denying claims based on policy, right? So if there's a policy and it's sort of related to fraud, waste, and abuse, but it's not necessarily to that egregious level, but we want to capture those claims, we've now moved to where we are putting in place edits where we'll reject or deny a claim based on policy, but then that information of what's being rejected also ties into our risk profiles. And if we see somebody continually bills us for things they shouldn't be billing us for, and we're rejecting a lot of claims, that becomes one more point of reference for our zone program integrity contractors and others. It feeds back into the system as well. So that really is really going to help us move and broaden the scope of FPS, doing real edits. We're also moving to where we're putting edits in place that would suspend a claim so that our RACs, our recovery audit contractors, can look at that, review that, send it back to us either to be paid or we need to take some type of other action. Okay, so again, I'm between you and lunch. I'll summarize things into implementing predictive technology and best practices. And these best practices come from not only our experience, but one of the things we've leveraged the command center for, and we haven't had a meeting in a while, but we need to get back to, is we have a federal work group. So we've been working with other agencies, the Department of Labor and unemployment insurance issues. We work with Treasury and the SNAP program, so supplemental nutritional programs. We've worked with SSA. So we brought folks together and we talk about various best practices or things that we're confronted with. One of the big ones was this measurement issue. And we haven't met in about a year, but we're going to do it again soon. But out of some of those discussions, we came up with some best practices that I think are high level and generic enough to think about whenever you're implementing a new technology. The first is you got to develop a robust process for incorporating field intelligence, policy knowledge, and clinical expertise in our case, but in other expertise relevant to your industry, right? You got to know where the people are, the frontline folks that are dealing and their business processes on a daily basis, and you have to make sure that you develop any of the predictive or other sophisticated algorithms with them at the table in order to ensure that the results or technology are actionable. You know, the opposite of eye candy for me is I'm a pasty-faced bureaucrat in a back room looking at data and I'm screaming at my computer, look at this, look what's going on, right? But I can't make that actionable unless I really understand the policies, unless I really understand what works for investigators, how they can move things forward, right? So you can't just rely on the data, you have to use that data in the context of the business itself. The second thing is you want to make sure that you develop the methods in advance for tracking, measuring, and evaluating all the actions that are taken on the information that's produced. You have to figure out a way, and there's a big investment here in people and energy around, you know, what are our findings? You know, we got this information in front of this group, they've taken that information and they've done something with it. You got to make sure you build in and track that and measure it so you can justify the investments on the technology front. and also to be sure that you're successful in knowing where you need to move. Fraud is not static, so we have to have processes in which we modify our predictive models, we enhance them, we shut them down, we bring in new ones, and that has to be cyclical, it has to be ongoing. The third thing is incorporate cost savings into the return on investment methodology to ensure the expenditures prevented are part of the savings. So we've shown that we found a way, and it's very conservative, but it's a way to start measuring prevention. So engage your actuaries, engage others, and think about what is it that you're preventing. Some of the challenges for us today are how do we start to measure sentinel effects, right? So example is when we refer to law enforcement, they'll take certain cases and others they won't, and then it's a long protracted case that goes to court, and then once you have court-ordered restitution and you got to pull the money back and all of that, you got to measure all that, and by the end of the day, the ROI doesn't look so great sometimes because we're not measuring a lot of other things, right? One, there's just a more moral imperative that if you have criminals, you got to investigate these criminals and you got to get them in court, right? Even though you stop the bleeding on the money front, you still got to get them into court. But measuring sentinel effects, such as, we have investigations going on in a particular area, our heat strike forces are in Florida, just the presence of them and just the cases that were prosecuted, how does that impact the costs in those areas? And sometimes we can't trace it right back to that activity, right? So we got to start figuring out a way to have a dialogue and talking about that, though, because if you have a heat strike force, you have law enforcement, you have the press, you have zone program integrity contractors, you have the FPS generating leads, all of those things in concert change the cost curve. Now, how do we talk about that? Because empirically, academically, it's kind of sometimes hard to have causality. Which piece caused this reduction? So that's a challenge for us. But you want to develop those things up front and figure out really what you're measuring to explain what your program is doing. The other is to develop an analytic environment for data exploration so that you can continue. And that's where we had the IDR, the talk we had a little bit earlier. That environment is robust for us. We can do a lot of research and development in that environment. So we talk about it, not in the government, we don't say R&D, but that's really what it is. It's research and development. The other thing is it's always important to have some knowledge in-house that understands the business and understands and can conduct your own in-house analytics. I think that it's really important as we're working with good contractors that are brilliant, but to learn as we go in terms of CMS policies, CMS environments, analytics, what's actionable, what's not actionable. You got to make sure you have some of that in-house too. And the last thing is develop and implement a governance process to prioritize program integrity vulnerabilities. So if you're not in program, anything that you do where it always takes a resource, you gotta have a governance around that to prioritize, because it's like drinking from a fire hose here. We know that we just have more than we have the resource to tackle, so we have to prioritize. Okay.
Perfect.
Thank you.
We have a few questions for you.
Yep, Kathy, you ready?
Do your savings include or exclude the cost of FPS in the administrative costs of ZPICs or PSCs?
Right. Yeah, they do include some of those costs. So what we had to do was figure out, the ZPICs do a lot of things that are outside of the FPS. So we had to figure out ways to impute what portion of their costs we're attributing to FPS-related work. And so we work very closely with the OIG on that. So it does include a lot of those costs.
Number two, not sure if this is relevant, but how does the UCM, Unified Case Management, described in our RFP for UPICs relate?
Yeah, they definitely do relate. So what we're trying to do with Unified Case Management, which is also in our group, is that we want to consolidate information around a lot of activities that are going on around providers, right? So that's our zone program integrity contractors, that's law enforcement, that's the RACs, that's the MACs. We want to know all of the touches that are going on with the providers. One, to be less burdensome on the provider community, right? but also that investigators in other areas will know sort of things that are going on with those providers. And that's just one of the many things that I want to do with the unified case management system. So the information from the fraud prevention system, while it's a standalone system right now and will continue to be for the foreseeable future, that information that comes out of the FPS will also be shared in that more community way through the unified case management system.
Okay, number 3, does CPI investigate potential fraud by beneficiaries?
Right. Our focus has been primarily on the physician, and we haven't, and I'm talking about the FPS right now. In other areas we do. But in the FPS, the provider has been our focus, and that will continue for some time. But there are other circles that deal with the complicit beneficiary that's a part of a scheme, that's complicit in that scheme, and so forth. But right now we are focused on the physician primarily.
Number 4, are you planning to expand your system's analytics capability?
Yes, we are, and I'm going to be careful about how I answer that. One of the great things right now is the period of performance on the existing contractors have run out, and we are now procuring FPS 2.0, and right now we're in that process. So I'll be careful about how I answer some of these because it's a little bit sensitive, but yes, we want to continue to expand and improve analytics in the system itself, especially around visualization, so that it's easier for the investigators to see certain things.
Number 5, will the dollar level of the referral be decreased to all law enforcement to go after smaller threshold pursuits?
Yeah, let me see if I can digest that one. Will the dollar level of referral be decreased to all law enforcement to go after smaller?
I'm assuming smaller dollar level. If it's $10, they're not going to bother with it, but if it's a gazillion, yes.
Right. Well, one of the things that we do in the front is, we have different criteria for how we prioritize which models go in, right? And so while dollars are not necessarily dollars at least spent or paid for is not necessarily a criteria for when we put a model, but the potential dollars can be large, right? So if we know that we put something in and we're preventing a large amount, even though an ambulance provider only billed us $4,000, but we were able to get to him after he only billed $4,000, but we know if we allowed that billing to continue, we could be spending a couple $1 million, right? So we would refer some of those still over. But law enforcement, they have their own prioritization, and they have to look at the dollars when they go in.
Do you see a growing interplay between the HFPP and FPS?
Yeah, absolutely. It's really important for us, and as we move forward, some of the future enhancements to the system is we want to bring in data resources, maybe as reference files or other things, from findings from the commercial side, private side, as well as triangulating with Medicaid data, Medicare Part C and D data, especially on prescribers. We want to expand and bring in those data sources. Again, we're very interested in a full book of business for a provider. If a provider's bad on the commercial side, it's likely they're doing something on the public side as well, and they're probably serving both of those types of beneficiaries. So it's really important for us to consider the findings and studies that they're doing as well. I'm the co-chair on the data analysis committee with HFPP, so we stay closely in tune with the types of studies that are being conducted.
Are you planning to integrate these systems to CMS's other financial systems? I made it a possessive there. Otherwise
no
the
worries.
sentence doesn't make sense.
Yeah.
I think that's what it means.
Oh, I see. I don't know how much we're integrating FPS. I'll probably have to get back with that question. I'm not sure I'm interpreting it correctly.
Anybody want to help? I know this is anonymous, but...
Anonymous. Yeah.
You'll have to repeat what he said, because...
Right. Right. So So the data does come in through the CWF right now, and so that's part of the claims processing, but it's prepay coming from there, and then we feed that back into the systems and our shared systems for any kind of actions or edits, right? But the things we have interest in terms of measuring our return on investment, some of our estimates are still estimates. We like to get to some actual. So we do work with OFM, we're working with High Glass and other things so we can get better at measuring overpayments and those sorts of things. So we do work closely with some of those financial systems for the purposes of measurement. But in terms of the editing and those features and how we get claims, it's in that claims processing.
Do you see FWA and provider quality analysis becoming more closely aligned?
Yeah, it goes back to my other answer is that I'll take any disparate data source and bring it in. And if you really think about, I guess, and again, I'll say a moral imperative, or if you think about the higher aspiration of what integrity is, I believe that quality is a big piece of integrity, right? And I think it is extra information that can be combined with other sources. So we're certainly looking into that, and I think we're going to work more and more in that in the future as well.
Okay. Thank you very much, Ray.
Okay, thank you.
So it's time for lunch. Before you run off, a couple of things. If you have a laptop or a laptop's probably okay. If you have one of those iPads, it's probably good to just turn it off and put it on your seat so that the batteries don't go dead over lunch. We'll be coming back at 1:15 and start precisely at 1:15. That's when the big hand, Mickey Mouse's big hand is on the 3. 3 is over here. No, it's on the 1 here. Speakers, if you get a chance, please go into Think Tank and provide responses. We'd like to post all this information afterwards so that everybody can see it. And so we'll have a Q&A and all the presentations will be posted for you to review. See you at 1:15.